So I'm going to be talking today about diabetes prevention. Uh, what we did is create a prediction model. The prediction model is for the allocation of the diabetes prevention program or for metformin to prevent diabetes. We developed a model that predicts risk of developing diabetes over 3 years in order to have more efficient allocation of these preventive measures. My name is Dr. David Kent, and I am the director of the Clinical and Translational Science graduate program at Tufts University. I'm also a general internist at Tufts Medical Center, and I direct my own research center, which is called Predictive Analytics and Comparative Effectiveness Center, or PACE Center. And I'm a professor of medicine. The title of the article is An Electronic Health Record Compatible Model to Predict Personalized Treatment Effects from the Diabetes Prevention Program across evidence synthesis approach using clinical trial data and real world data. And it will appear in the April edition of Mayo Clinic Proceedings. About 1 out of every 3 adult Americans has prediabetes. And what prediabetes is, it means you're at risk for developing diabetes. It's been shown that there are certain therapies that can prevent the onset of diabetes. Indeed, the Diabetes Prevention Program trial, which was published in the very early 2000s, enrolled 3,000 patients, and it randomized them to 3 arms: usual care, an intensive lifestyle and modification program, which included classes and diet and exercise, and also metformin therapy. The lifestyle modification arm reduced the risk of developing diabetes by about 58%, whereas the metformin reduced the risk of diabetes by about 25%. Now, nevertheless, these treatments really have not disseminated into the broad population. And one reason is that, the capacity to really implement this intensive lifestyle therapy for 1/3 of the population can overwhelm practices. And so back in 2015, together with colleagues at Michigan, we created a risk model for the development of diabetes, and we stratified the trial results using this risk model, and we found that most of the benefit of either lifestyle modification or of metformin therapy can be obtained really by treating just the highest risk patients. So for lifestyle modification, what we found is essentially everybody gets the same 58% relative risk reduction. And when your relative risk reduction is roughly consistent, then obviously the high risk patients get more benefit. And for metformin therapy, we found that the benefits were even more skewed. The high risk patients actually got most of the benefit, even more relative benefit than average. Instead of a 25% relative risk reduction, which was the average relative benefit, they got roughly a 50% relative risk reduction. And the lowest risk group, the lowest risk quarter of patients, actually got no benefit whatsoever. And the intermediate patients got intermediate benefit. Now, the problem with the model we developed back in 2015 is that it had variables that are not routinely ascertained in routine clinical practice, such as waist to hip ratio, which is generally, we as physicians really don't know how to measure that accurately. And it's certainly not available routinely in an electronic health record. So with funding from PCORI, who funded our original risk model, we developed an electronic health record compatible model that used variables that are routinely ascertained from the EHR that would automatically calculate the risk of developing diabetes in 3 years. We ported that model from the EHR back into the diabetes prevention program study, and we checked to make sure that we got the same results that we did the first time, and indeed we did. It turned out that basically 77% of the benefit of population-wide therapy can be obtained just by treating half the patients with lifestyle modification, and over 90% of the benefit of population-wide metformin could be obtained by treating just the highest risk half with metformin. So the idea is you can gain enormous efficiencies by risk stratifying the population. This model that we developed was developed using data from Optum Labs. We developed the model in 1 million patients with pre-diabetes. And then we ported the model, and then we tested the patients, we tested the model in another 1 million patients. And the performance in the test population was actually even better than it was in the derivation or development population. Those in the lowest risk decile had a risk of developing diabetes in 3 years that was roughly 3% or 2 or 3%, whereas those in the highest risk decile were close to 30%. So there was roughly a 10-fold difference in the risk of developing diabetes. And when your risk of the outcome varies that much, then the benefits of therapy are really going to vary quite a lot too. And that's what we found. The idea behind this research is that we have to move beyond a one-size-fits-all approach. Many patients are reluctant to start a new medication unless they think it's going to be worthwhile, unless the benefit is above some threshold that exceeds the burdens of taking the medicine and any potential side effects from taking the medicine. And similarly, with an intensive lifestyle program, it is really a big commitment to take this lifestyle program, to change, to modify your diet and to exercise to that degree. And people do want to know what their individual benefits will be from embarking on that. What we found, and then for physicians, it should also be said, for the system, it should also be said that there are capacity issues, right? So the capacity issues there is that there are only so many of these DPP programs, and they don't have the capacity to treat the 80 or 90 million patients in this country who actually would qualify in terms of having prediabetes. So what we found is that we can get most of those benefits by treating the top half or even the top quarter of patients in terms of risk of developing diabetes. We've already implemented this model, and we've implemented this model in, we've partnered with AMGA, which stands for the American Medical Group Association, to incorporate this model directly into EHRs in Pittsburgh and St. Louis, and to create an app that's hosted in the cloud and that could really connect to any EHR. It's interoperable with any EHR. And what we found, at least in our Pittsburgh location, is that referral to the DPP program went up tremendously. And the reason it went up is because really they did not have the capacity to treat everybody with prediabetes who could, might have qualified for the DPP, but they did have the capacity to refer a quarter of the patients, and that's what they did, rather a third of the patients. So they decided to use the model in order to target the therapies to the top third of patients. And I think roughly 77% of these patients were actually referred for the DPP using the model, when before the model was implemented, it was close to zero. So we plan actually to further disseminate this model into other EHRs. In another PCORI-sponsored project, its use is being examined at UCLA and the University of Utah. And as we get more data, we'll be able to better estimate the effects of this decision support tool. So it's been a pleasure talking to you today about my research, and I really hope you'll take a look at the April issue, and you'll read the article, and you'll send me your thoughts or critiques. Thank you very much.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.